physiology of transpulmonary pressure. It's becoming a lot of talk of town. A lot of adult units regularly measure or depend. A lot of literature is coming up in it. And several pediatric units are considering or are already doing it, while measuring esophageal pressure to know what transfer. But before we know the technique of esophageal pressure, before we know why should we measure esophageal pressure, we should know what is it that esophageal pressure gives us? What is it that we need to use at the bedside as information from the measurement of esophageal pressure that will help us titrate ventilation or treat our patients better. And so I thought we should have some idea, some talk about physiology of transpulmonary pressures. Why is transpulmonary pressure relevant? You know, we are into personalized medicine, and as it's drugs, so is going to be technology like mechanical ventilation or ECMO and stuff. One size does not fit all. This is a slide made by one of my colleagues and fellows, Aviad Rosenberg. You know, he was trying to explain why esophageal balloon manometer is important. The gentleman on your left certainly has a thinner build, and the pressure that his chest wall is going to exert is much lower than the gentleman on your right. So the airway pressure which is applied to the respiratory system affects lung and chest wall differently in different patients. So what we give at the airway, which is at the endotracheal tube, will be used to inflate the lung and to push the chest wall away. If the chest wall is thicker and is exerting more pressure, then more pressure will be required to move the chest wall. Also, we know that chest wall mechanics can be severely abnormal in critically ill patients. They need not be fat, or they need not be obese, super obese, etc. There may be a lot of chest wall edema. Paralysis can do a lot of stuff. Abdominal contents can push stuff in passive ventilation. So there are many reasons why chest wall mechanics will change, and therefore the understanding of chest wall mechanics at the bedside may be helpful. Everything that we know in literature about chest wall and lung, a lot of it is through the measurement of pleural pressure, but a large amount of it is through the measurement of esophageal pressure. And that is in scientific literature, it has been for more than 50, 60 years. So it's not something very new. The new part about it is being able to use it at the bedside in an informative way. So now this is a very good schematic representation back in 2004 in the blue. You know, why trying to justify why transpulmonary pressure understanding is important. You know, the alveolar pressure, which is at static PA airway pressure. Now we give the airway pressure here, which is what we measure as Peep or peak pressure. And if we zero the flow, the airway pressure that we measure here is the plateau pressure, as we all know that. The alveolar pressure and the airway pressure will equalize if there is no flow, which is to say that plateau pressure is the alveolar pressure at the end of inspiration, or the total PEEP is the end expiratory pressure at the end of expiration. The pressure applied to the respiratory system is this pressure minus the atmospheric pressure, the airway pressure minus the atmospheric pressure. The part of resistive component goes away in zero, therefore plateau minus the airway pressure or the atmospheric pressure, which is zero, which means plateau pressure itself becomes the pressure applied to the entire respiratory system after the resistive forces have been overcome. But it has two components. One is the transpulmonary pressure. So this is the trans pressure of the trans respiratory system pressure, transpulmonary pressure, and trans chest wall pressure. The transpulmonary pressure is the airway pressure, or now the alveolar pressure, minus the pleural pressure. Whereas the chest wall pressure is the pressure in the pleura minus the atmospheric pressure. So what we don't know at the bedside often is the pressure in the pleura. One can now appreciate that whatever we gave here, depending upon how thick, how small, how different the chest wall is, part of it is going to be used up for this and part of it is going to be used up for that. Another schematic representation to illustrate the same point. So transpulmonary pressure is the airway minus the pleural pressure. For the same airway pressure, the transpulmonary pressure can be lower if the pleural pressure is higher. And for the same airway pressure, the transpulmonary pressure can be higher if the pleural pressure is lower. which is to say that when we measure this at the bedside, we do not know what this pressure is, which is actually distending the lung. The transpulmonary pressure is now becoming to be known as lung distending pressure. Why is it important? It is the pressure that is applied to the respiratory system after taking the chest wall component away. Therefore, it actually measures or gives you an idea of the stress that the lung sees itself. Last time we saw how ventilator-induced lung injury contributes to mortality and everything. And the simple classic experiment that Dreyfus and colleagues did, where they banded the rats with, they banded the chest wall and gave them high inflation pressures, but the lungs did not seem injured. This is because when you band the chest wall, all you're doing is decreasing the chest wall compliance or increasing the pleural pressure, which means that high inflation pressure that was given to those rats was largely used up to move the chest wall, and it actually did not distend the lung too much. So the willy was much less. Since then, it has been understood that it is the lung distension that will matter. And the lung distending pressure, therefore, probably may help us understand or titrate ventilation at the bedside to prevent willy. So two important mechanisms, many mechanisms of willy that we've seen, but two important at the bedside that we can probably make a difference, and we talk about that over and over again, is overinflation from high stretch, that we have a lung getting more and more stretched, which is hyperinflation injury, and or if it is not adequately open, then the alveoli at the end of expiration might just completely closed and then again open and then close and then open. This opening and closing of alveoli can be injurious. As we'd seen last time, Parker had shown that cyclic inflation has much more permeability than static inflation, which sometimes in literature gets called as volutrauma and atelectotrauma. This is just, I'm putting up here because a lot of people refer to this in a very different way, but volutrauma we know as a distension-induced lung injury. There is some evidence to this that we understand, and there is several good evidences, but this is the most famous paper that gets quoted, and we know that overinflating with 12 ml per kilo is injurious. But if we give 12 ml per kilo or even 6 ml per kilo without adequate PEEP, it may be still opening and closing, and therefore a lot of studies have been done and being considered to figure out what that optimal PEEP is. But we haven't really found a good answer to this. This one did not show any difference between high and low PEEP. This did not show much difference, and even this one. Why is that? Because none of these studies consider individualization of PEEP for the patient. There are several ways to individualize. There is much more literature coming up of interaction of PEEP with airways, that is airway opening pressure, the PEEP and prone position, etc. One of the components for individualization of PEEP is also the chest wall mechanics. None of these were accounted for. So blindly setting a PEEP, well, I would not say blindly setting a PEEP. Clinically also, probably we do much better than these studies that we titrate PEEP to either respiratory mechanics or gas exchange, one of the two. Most of the time it is the gas exchange that we run behind, and that sometimes might be overstretching the lung. That is the real concern. But several of these studies had just assigned PEEP, which is a little bit interesting and a bit confusing for me. Here today, we will talk about chest wall compliance, that being one of the factors in which we can individualize PEEP. What is now famously called in the literature is the direct method of transpulmonary pressure, which is simple and understood. As we said before, direct method is where you measure the airway pressure and you measure the pleural pressure, in this case esophageal pressure. We'll come to the esophageal pressure in a minute. You subtract the esophageal pressure from the airway pressure, and what you get is the transpulmonary pressure. In this example, for instance, the PEEP here is 14. There is no flow, so this is the auto PEEP. The esophageal pressure at that point is 17. 14 minus of 17 is -3. And you can see the transpulmonary pressure goes below 0. So it is negative transpulmonary pressure. What does this mean? How do you imagine this? That when the pressure outside the lung is higher than the pressure inside the lung, which is to say the pleural pressure is higher than the airway pressure, as in this example, the lung will collapse, right? The lung is likely to collapse. It's a balloon where it takes a pressure to inflate it, but if the pressure from outside is higher than the inflation pressure of the balloon will not inflate. In our mind at the bedside, we think that we've given a PEEP of 14, which should be inflating the lung, but maybe it does not in this example, for instance. This is what is the philosophy behind it. To a large extent, it is true. Now, in this example, this is a bedside example in a child. I don't remember the pathology. This was several years ago that we measured on GE. And here, the GE has a facility of measuring auxiliary pressure. I think some other ventilators too. I'm not here to sell a particular brand of ventilator. But you can do this either on the ventilator or even on your monitor on the screen, which will give you values in millimeters of mercury, and then there are ways to convert it, etc. But there are innovative ways. It need not be a very costly affair. You get this esophageal pressure in real time below the airway pressure, and you know that the peak airway pressure, which is 33, and the peak esophageal is 13. 20 of transpulmonary pressure here at the end of inspiration, and at the end of expiration, it is about 8 minus of 7, which is 1. We'll see in a minute what these values should be like, but this seems to be a reasonable place for this patient, at least from the expiratory pressure point of view. Yet another example, this is all published in literature. Here you see an airway pressure where the PEEP at the time of zero flow, which is expiratory hold, is 20 centimeters, and you can see the esophageal pressure, which is above 20, somewhere close to 25. So the transpulmonary pressure is less than 0 or negative, which implies that likely the lung will get closed. Changing this PEEP from 20, titrating it upwards, maybe around 25, did not change the esophageal pressure too much, which means the airway contribution to esophageal pressure was not too much. Largely that esophageal pressure came from either profound lung weight, or more likely, it comes from the chest wall itself. So it did not change, and increasing the PEEP changed the transpulmonary pressure to less than 0 or slightly 0, less, maybe if you go even higher, it will be more than 0. The central idea here is that this may allow you to use PEEP, which is higher than what we generally do, knowing for sure that not all of this PEEP is actually distending or stretching the lung. This is helpful at the bedside. One of the key papers for this directly measured transpulmonary pressure or esophageal guided ventilation acute lung injury was back in 2008. This was EpiVent 1, and then there's been EpiVent 2. Both of these did not show really positive result towards the use, and there are several reasons that one can figure out. What they did in the first study, and something similar they kept doing, is that the transpulmonary pressure they used was a various range at the end of expiration, from 0 to 2 to 4 to 6 to 8 to 10. Now that is a little bit hard. When you keep increasing a lot of transpulmonary pressure, which is making more and more positive, then where you believe that you've reduced atelectatic trauma, it is likely that you've caused overinflation trauma, which is the other end of the problem. And therefore, one might not see benefit in mortality or change in or reduction in ventilator-induced lung injury as a mechanism to reducing mortality. Maybe, maybe not. They were doing it in this group. The control was the Peep FiO2 table of the low Peep FiO2 table. In the second study, it was high Peep FiO2 table. So in this first study, they did show some signal toward mortality. This is a mathematical value. But in the conventional arm, 12, and in the esophageal guided arm, 5. They did EpiVent 2, did not show much of a difference. But very recently, just this month, I think, 15 days ago or something like that, they have published a re-analysis of the EpiVent 2 trial. I'm not getting deep into EpiVent 2 because that becomes more epidemiologic discussion. We want to stay with physiology today, and this is for trainees, so we'll stay with physiology. This is a very interesting reanalysis. What they did is they took all the patients where they had applied esophageal balloon manometry and calculated transpulmonary pressure, and then divided them into low Apache and high Apache. This, of course, is all post hoc and repeat analysis, so sometimes it's some strict epidemiologist will be very criticizeful that you can't do this, but I think it gives us very good insight into where this might be useful or where this might not be useful. They show that in low Apache, this is an adult study, which is to say that not very sick patients, which can take more lung inflation, a PES guided PEEP had benefit on survival. Whereas if the Apache was high, that is very sick patients, similarly they're hemodynamically unstable, they have more inflammation, etc. Giving PS guided PEEP, which is the PEEP would be very high at times, did the opposite effect, reduce their survival. Whereas the empirical high PEEP, which is high PEEP FiO2 table, was same in both groups. This probably gives an idea that not in very sick patients, maybe using esophageal balloon manometry is a good point. As much as this result is interesting, to me, the most interesting result is this point, which I think probably gets us to the idea of why using good bedside physiology can be helpful. What they also showed is that if the end expiratory transpulmonary pressure is kept within a range of plus minus 2, in the sense around 0 to 2, maybe little sometimes less than 0, then the survival benefit is quite significant compared to when the transpulmonary pressure is always less than minus 2, that means the lung is always closed, or the transpulmonary pressure is always more than 2, which happened in many of their patients, which is, you have an expiratory transpulmonary 4 or 6 or 8 or 10, then again they will not survive. This makes sense. This makes sense that overstretching the lung by using a new technology, thinking, okay, this is going to be helpful, also is not going to be helpful, is also not going to make sense. So at least this tells us, and this is also from a lot of clinical, well, not say let's say clinical, a lot of experimental data, discussing with some of the key leaders in the field. One of the experiments that, for instance, Dr. Marcelo Amato, one of his talks, he was saying, if you take the lungs out of the chest wall from a pig, like just bring out a lung, and start inflating them with PEEP, the best PEEP at which the entire lung will inflate is just 2 centimeters of water, which is without the chest wall, which is basically the transpulmonary pressure applied to that lung, which is 2. So this value of plus minus 2 comes from a lot of understanding of physiology already, and that's the reason they picked it up and they tried to analyze whether that will give us a signal, and that probably does. Of course, for all the folks who believe in absolutely randomized controlled trial as the key thing for evidence-based medicine, we will have to see whether in prospective trials this will show up. But physiologically, it makes sense. So, and I think physiology is also good evidence to bedside practice. So positive transpulmonary pressure around 2 makes sense. Now here is a little bit older concept, but physiologically very, very good. And this was proposed by Dr. Gattinoni, and phenomenal physiology. Dr. Gattinoni suggested back in 1980s that ARDS probably is physiologically or etiologically is of 2 different groups. We keep learning and teaching, but it goes in and out of literature. One is pulmonary ARDS, which is where the lung itself gets bad. The infective agent has gone inside the lung, or there's an aspiration, the COVID pneumonia, staphylococcal pneumonia, something like that. And this leads to increase in lung elastance. Back in those days, elastance was being more important, but we know that elastance is reverse of compliance, and now in literature we use a lot more compliance. It's the same thing. So increase in lung elastance, which would mean decrease in lung compliance, which is primarily the lung. The chest wall is not too much affected. And then he said that extrapulmonary ARDS, which is where the ARDS originates outside the lung. Well, the ARDS originates in the lung, but the etiology outside, in the say sepsis, pancreatitis, and there's inflammation that goes on systemically, which then leaks into the lung. There is a heterogeneous spread, or there are many, many factors why systemic inflammation will eventually lead to pulmonary injury. So in those situations, it is largely the chest wall that is in trouble, because you may have edema, you will have abdominal pressure which is high, etc., etc. All of that makes sense. And so he says if you have pulmonary ARDS, then looking at lung as directly and not addressing chest wall might be okay. Whereas in extrapulmonary ARDS, It is the chest wall elastance, so keeping it into a factor is very, very important. Here, in this example, this terminology is a little different, but what he refers to here is the delta transpulmonary pressure. Delta. Now, let's go back. This is 1998, and driving pressure has become more famous from 2015 onwards. But delta airway pressure applied to the respiratory system, once you take the resistive component out, is basically the driving pressure that we know in literature today. It is plateau minus P. So the driving pressure of the respiratory system, as much as that was a static pressure in the previous thing that we saw, which is P minus the esophageal pressure, the driving pressure of the respiratory system, which is plateau minus P, will have two components. We'll have a driving pressure of the lung and the driving pressure of the chest wall. Therefore, the driving pressure of the lung, or the delta transpulmonary pressure. When we use a lot more terminology, it becomes more confusing, but it is simple to say that driving pressure, which we measure on the ventilator, has two components: driving pressure of the lung and driving pressure of the chest wall. So the driving pressure of the lung, or the delta transpulmonary pressure, is therefore the driving pressure of the airways, which is the ventilator measured driving pressure, minus the driving pressure of the pleura, which can be measured by using the esophageal balloon. So you get the driving pressure of the lung, the pressure that actually drives the tidal volume inside the lung. Now this is a mathematical concept, and this is the physiological divide. Here is an illustration which explains this very well from his work, that for instance you applied a 30 centimeters of delta transpulmonary pressure, a delta airway pressure, which is pretty huge, but this is back then, this is more of illustration. So don't go by absolute numbers. It is more of physiology that one needs to understand here. So the 30 centimeters of water, when you apply a driving pressure in this lung, the component of the chest wall is only 20% of the respiratory system. This is all written in E, and E, which is elastance. So 20% component of the elastance of the chest wall is part of the respiratory system elastance. The reason he has chosen elastance, and actually elastance is mathematically easier, because elastance of the respiratory system is equals to elastance of chest plus elastance of lung. It is easy. When you do compliance, it is 1 upon the compliance of the respiratory system is equal to 1 upon the compliance of the chest wall plus by 1. So it becomes mechanically complicated to calculate. So when we say elastance, it is 20% of the elastance of the respiratory system comes from chest wall, which means directly mathematically you can say that when you apply a driving pressure of 30, 6 centimeters will be used to move the chest wall. Fair? And 24 is used for the lung. This is normal chest in an ARDS, which says that what you do here largely goes to the lung, and therefore limiting here is important. Contrast this with a stiffer chest, a lot of fluid overload, pancreatitis, abdominal this thing, etc., etc., and you have a pleural pressure, or driving pleural pressure, or driving chest wall pressure of 18 centimeters, or 60% contribution to elastance of the respiratory system. Then what we give here largely goes to the chest wall, and the lung receives it much less. This may be safer from overinflation, or it may be inadequate for a proper tidal volume delivery. So we say, well, you're still within quite a good range, and what you give here does not go to the lungs. Better, you can increase your airway pressure and give more airway pressure, which is safe in this situation. This illustration demands a knowledge of the pleural pressure values, right? Without which it is very difficult to do this at the bedside. Here is the actually measured example about pulmonary and extrapulmonary ARDS. We'll look at in terms of how it is directly measured, but it's more of an illustration again. You can see here that so the upper graph is flow, which is easy to recognize, and then here is esophageal and airway pressure superimposed on each other. This is pulmonary ARDS, which means the lung elastance is bad or high, or lung compliance is low. And when you give the airway pressure, which is this, the tidal airway pressure, which is going up and down, you see the esophageal pressure changing, but not too much, changing, but not too much, which means that all the pressure that you're applying is not moving the chest wall too much. The chest wall is easy. It's not getting used there. And largely, when you take the difference between airway minus the esophageal, which is the transpulmonary pressure, it is being applied to the lung. You can see the lung is getting inflated from close to around 0 to -2 to almost 24, and that way opening and closing. So overstretching and maybe closing at the end of expiration. So this is what pulmonary ARDS will look like. In extrapulmonary ARDS, it is probably a little bit opposite. You see this airway pressure given from 10 to 40, which is kind of really similar to what is being done here, but the esophageal pressure base value is higher because the chest wall is thicker, the load of the chest wall is higher, the abdominal content is maybe pushing something, whatever the example may be. And then with every tidal breath, the change in esophageal pressure is also much more pronounced than here. You don't see a very good cardiac oscillation, which you see here, but this is well placed. So what it says is a lot amount of pressure that you're giving in the respiratory system, which is the airway pressure, is used to move the chest wall. And when you do the subtraction, you see that it's going from -16 to +8, -16 to +8. Here probably it is getting overstretched at the end of inspiration. Here at the end of expiration, that is getting completely closed for sure with such negative transpulmonary pressure. And there is barely any lung distension with inspiration, which means probably this patient is underventilated or not adequate volume goes inside. This is how one can know that for the similar amount of airway pressure, actually what the lung is seeing is very different in both of these conditions. This may be a patient where you could safely increase the airway pressure to overcome this. And here is a patient where you'll have to decrease the airway pressure because you're overstretching the lung. That kind of an example. Now, this is a little bit of a difficult mathematics, but worthwhile. And now there are automated online calculators, and I'll show you one which was developed in Toronto by one of our famous respiratory therapy colleagues, Thomas Barino. What is this mathematics? Let's understand physiology first. We said delta airway pressure or driving pressure is equal to the component of these two. Now divide the entire thing by tidal volume. Then you come to this equation, which we said before, elastance of the respiratory system is elastance of the lung and elastance of chest wall. Airway pressure divided by tidal volume is elastance. Tidal volume divided by airway pressure is compliance. All right, because we are so used to compliance, maybe it takes a little bit of time. I'm happy to share the slides so you can go and read Tomaso's paper, and it will throw probably much more light. The elastance of the respiratory system is there for the addition of these two. And so if, for instance, you want to know the delta driving pressure of the lung, like the delta pressure of the delta transpulmonary pressure, driving pressure of the lung, then it's the driving pressure of the airway multiplied by elastance of the lung divided by elastance of respiratory system. You will come from here to here. So if you know the ratio of elastance of lung to elastance of respiratory system, then you will know what the driving pressure of the lung is like. Driving pressure of the lung is the stress applied to the lung. The stress and strain are linearly related, as we know. The normal ratio of EL to ERS is 0.7, which means lung takes maximum part of the respiratory system. 70% goes to lung, 30% of the chest wall. But if the chest wall component increases and this EL to ERS ratio reduces, then for the same applied driving pressure of the lung, the driving transpulmonary pressure, the driving pressure of the, for the same applied driving pressure on the ventilator, the driving pressure of the lung will be lower. As it is so hard to keep up with these terms, but I hope I'm not confusing you. Here's another very cool example that Grasso and colleagues published using pig models and stuff. And this was to show that why just using universal PEEP might be not a good approach and why chest wall needs to be considered. Again, the values are not to be taken as it is and applied, but it's a very, very cool illustration. Before we go that, let's look at this Hounsfield unit colorization. This is a CT, but this has been then colored. You know, when you have a Hounsfield unit which is positive, then the density is close to water, which is to say that there is a lot of collapse or consolidation. So all the red means thick collapse and consolidation. Now don't look at the red around that, it's chest wall, heart and everything. We need to look at red within the lung regions. When you color the CT's colors everything else, so it's difficult to tease that out, but this is the red that you would look at when we're looking at the lung. And as you go towards -1000, which is largely air, which is no water, it would indicate hyperinflation or over distension, because there is more and more only air and there is no place of tissue kind of stuff. The normal Hounsfield unit for lung, we'd appreciate if it is between 500 to 900, that would be perfect. That is, large part of it is normal. Certainly we don't do CTs in humans that often, but this helps understand experimentally what's going on in the lung. Now here, the elastance of the chest wall is 37.3 centimeters of water per liter, which is to say it's a pretty good elastance. And the Peep applied is 8. By the mathematics that we saw earlier, the transpulmonary pressure applied to the lung, which here is calculated as plateau at the moment because they have not considered Peep in, so it's not a driving transpulmonary pressure, but a plateau pressure of the lung, not the plateau pressure of the respiratory system, is only 16, whereas the plateau pressure applied to the respiratory system, which is on the measured on the ventilator, is 29. So you think 29.3 is all good, there is no problem, and you're on a Peep of 8, fantastic. This was before the driving pressure concept came in. Otherwise, we would have said no, the driving pressure is high. But when you look at separation between elastance of chest wall and lung, you realize that the plateau of the lung is actually very low, and the lung is not very well inflated. You can see a lot of collapse, a lot of red, and a lot of yellow. Yellow also is close to collapse. It is poorly in what do you say, in CT literature, this is called non-aerated, poorly aerated, normally aerated, and hyper-aerated regions. This is how it gets defined, and therefore those markings. So you can see that the amount of non-aerated and poorly aerated areas is quite a lot, despite you giving a Peep of 8 and a plateau of 29. So on the bedside, you think it's all good, but probably it is not that good. This patient is this animal or a similar patient is hypoventilating. Whereas when you know that, you say, okay, my safe limit for this can be higher, which is not now this value, which is probably considered lower than this value. But to achieve this kind of a value, I'm okay to go up on the airway pressure. So I increase the Peep, but not the plateau, because I want to open up the bases of the lung. And that is something that is difficult for everyone to realize, that Regatinonian group did not say that because you see this less, you just increase the plateau. That will increase the driving pressure. No, they said actually increase the Peep, because that is what is probably required. And you go from 8 to 24, the chest wall elastance actually hasn't changed, which you can see this is a thick chest wall. The elastance of the chest wall now will not change, but the Peep induced aeration of the lung changes. You see a lot of normally aerated areas. There is in fact some hyperinflation happening already, which goes to say why this value now is considered a little bit higher. And the plateau in this situation at the moment is 44.5, and we're like, who is going to ever ventilate anybody with 44.5? Again, I'm not suggesting that we should just blankly copy this. This is more of a physiology class to understand when we do any changes on the ventilator, how does it actually translate and what does the lung see? Lot amount of emphasis has been on setting the ventilator on modes and stuff. But what we need to imagine and figure out, what is the lung seeing? What is important is the lung, not the mode and everything else. And if the lung is getting stretched or you're doing wrong things with the lung, then it doesn't matter whether you're using the most sophisticated mode, it will still be wrong. For instance, this can be simply applied to APRV, which is becoming very, very famous. But if you apply a very high T high, and if the patient is breathing on top of that, we'll come to that, the dynamic lung stress or the driving pressure of the lung will be very high. And if we don't measure it, then we think, oh, we applied APRV, he should be fine. No, no, no. That may get us into trouble. This is my point here. Now, so much of a physiological talk. At any point, if you think that this is not going very well, you need to stop, then we'll go ahead. No point. We can rediscuss, we can re-talk. You know, I'm not able to see everyone, but I hope everyone is here. Hello?
We are here, Dr. Pursa.
Yeah.
Okay, all good so far?
Yeah.
Great. Okay, now here's this calculator online that I was talking about. It you can go on rtmaven.com and download it, etc. Or you can Google out Thomas Perrino and you will see a lot of stuff. You can also go to Center of Excellence in Mechanical Ventilation website, COEMV, which is run in Toronto, and they have all of this there. Here's another example of a clinical patient in the ICU, and this was when I measured this esophageal pressure. She's a girl Um, I think she's 12 or 13 years old with pancreatitis, with significant abdominal distension. And, she's being ventilated on a reasonable pressure. The lungs were not bad when she was being ventilated. And when we were called in to help with ventilation, it was, on a 23 on a pressure of 9, which is reasonable, right? This is a good airway pressures for her lungs, which were not that leaky and stuff. But the clinical question was that, she's hyperventilating, the oxygenation is also not getting good, CO2 is rising, and what can we do beyond these pressures? And she's not ARDS and stuff that we need to go up much more on the PEEP and stuff. And she did not seem very obese or stuff. The abdomen was distended, of course, and there was an acute abdominal condition, which is entirely independent, has to be managed. And that is where the major part of the money of managing that patient would lie, just clarifying. But we said, okay, until everything gets sorted, if we have to do a good mechanical ventilation, let's pop in an esophageal balloon and let's measure esophageal pressure. And you can see here at the end of expiration, the esophageal pressure is close to 11, which is a negative transpulmonary pressure of 2, which is getting the lung closed at that time. This is not a heavy lung like ARDS, but maybe it is becoming leaky in the presence of pancreatitis. And here you see at the end of inspiration, the delta change in the esophageal pressure is pretty huge, which is like the example of extrapulmonary ARDS as we saw in literature, which is what this clinically at the bedside is. And you see it is 22 here, which means at the end of inspiration, the transpulmonary pressure is just 1, which is a very low inspiratory transpulmonary pressure to inflate the lung properly. I said, okay, this is concerning because huge part of the airway pressure is therefore getting used 22 by 11 for a 23 by 9. That means majority of it is getting used only for the chest wall. This is what I wanted you to appreciate. You see the EL by ERS ratio in this situation is 0.2, which should be normally 0.7 to 0.8, which means the elastance of the chest wall is pretty high. This is despite a driving pressure of 14. So on the ventilator, you see, the driving pressure is 14 and the compliance is 19, which is low. And I don't think I can go up. But truly, all of it that you're doing is only ventilating the chest wall or getting that pressure to the chest wall, but not to the lung. And then, of course, we made ventilator changes to help her and stuff, and she got out. But this is a physiological illustration. Now, how does the two tie in? How do the inspiratory transpulmonary pressure, the indirect method, which Dr. Gattinoni suggests, and the direct method that Dr. Talmor and group suggested, or basically a physiology, we want to call it the mispresent, but basically this is simple respiratory physiology. How do they tie in? And I'm sorry I didn't put in here, but this is Takeshi Yoshida again, phenomenal paper in 2018 in the blue, where in lung injured pigs he showed that when you have a dependent and a non-dependent sensor, so there were sensors measuring the pleural pressure directly, and when you use them for transpulmonary pressure measurement at the end of inspiration, and then you have esophageal pressure, which is this black line, and then the elastance ratio, which is the ratio that Dr. Gattinoni mentioned, that is the red line. He said, how does all four compare? These are directly measured values. This is can be measured at the bedside, and this is mathematically estimated at the bedside. Look at the beauty. Let us go through each of this a little bit carefully. So let's look at the dependent sensor, which is this one. When we measure the dependent sensor and a directly measured inspiratory transpulmonary pressure, which is to say airway pressure minus the pressure measured in the dependent lung, which is in the dorsal part, then it is these values at the end of inspiration. So for a PEEP of 4 to 24, at the end of inspiration, the dependent part of the lung is only seeing 5. And as you increase the PEEP, it will go maximum to 10 of transpulmonary pressure, something like that. If we compare that value to the esophageal balloon manometry, then they are pretty similar, a little bit different, but pretty similar, which suggests that esophageal balloon manometry probably gives the value very close to the dependent lung, which makes sense because esophagus is in the posterior part, so it probably measures the dependent part of the lung. In humans, the chest wall in the back becomes a little bit more curvy, so the esophagus comes little the most dependent part, and so it may not represent the most dependent, but still it represents the lower half, or that represents more of dorsal than of ventral. So when you do esophageal balloon manometry and directly measure transpulmonary pressure, it is measuring the transpulmonary pressure of the dependent lung regions. This is a very good insight. Now they also had a non-dependent, which is in the ventral areas, And they said for the Peep of 4, the inspiratory transpulmonary pressure here in the ventral area is already 10. And if you increase the Peep, it goes to 15 plus or 17, 18, which is hyperinflating that area. How does this compare with what Professor Gattinoni was talking about, the plateau pressures? And when we did the mathematical calculations, were, Takesh and group found that this value, which is derived from the elastance measurement or elastance ratio measurement, is very close to the directly measured non-dependent or ventral sensors. Which is to say, now at the bedside, we have an estimate of the inspiratory transpulmonary pressure through mathematical calculation of the non-dependent regions of the ventral regions, and using esophageal balloon, we have a measurement of the dependent transpulmonary pressure, which is fantastic because using the esophageal balloon itself, even this value, friends, you got to realize that the ratio is calculated using esophageal balloon manometry. The mathematics is like that. So with the use of esophageal balloon manometry, at least in the supine position, we can calculate a dependent and the non-dependent lung stress at the end of inspiration, which is fantastic. So you can know what expiratory transpulmonary pressure is, what is inspiratory transpulmonary pressure, etc. And that is what in this example, as we said, the inspiratory transpulmonary pressure directly measured is 5, but elastance is 1 and elastance derived is 5, which is to say that in the dorsal areas, this girl was getting only 1 of inspiratory transpulmonary pressure, only 1 centimeter was opening her, and she was getting 5 in the non-dependent areas, which is also low. That means most of her lung was not getting inflated. I haven't put her X-ray here, but the lung volume was very, very low. This is as simplistic as it can get. Of course, lung is not just about ventral and dorsal, it is superior, inferior, and there are several regions into which what we do on the tube probably gets distributed in terms of volume in a very, very different way. But from the idea of personalizing ventilation, this probably gets us a step closer to managing each patient very well. Now, last thing about dynamic lung stress. There is a lot of literature here too, but more importantly, understanding the physiology. This is very key. For instance, here is the airway pressure and the esophageal pressure. The airway pressure is set around 20 to about 15, 12, and the patient is also breathing a negative 10 below the PEEP. Then there is positive airway pressure. Patient breathes again a trigger, and the airway pressure is given by the ventilator. If you put in an esophageal balloon, you will know that the negative pressure comes, or the lower swing, let's not say negative pressure, which starts from here, is here, and then esophageal pressure also becomes positive as the airway pressure increases. This difference from the total inspiratory pressure to here is the delta esophageal pressure change, right? So if you calculate airway pressure minus esophageal pressure, in this graph, what we know as the transpulmonary pressure, the transpulmonary pressure is not in this segment alone. The transpulmonary pressure is from here to here, as you can see, which is the dynamic transpulmonary pressure, which is to say that the pressure on the ventilator and the pressure on which the patient is breathing both get added up to distend the lung, which makes simple physiological sense. And that value can be measured using esophageal pressure changes. And this dynamic transpulmonary pressure is going to be higher than the driving pressure that you're measuring on the ventilator, which means even if you are safer on the driving pressure on the ventilator, but the patient is taking extra 10 centimeters of water, that gets added to the 15 centimeters, and you're probably seeing a lung distension of 25 centimeters or more, which is going to be deleterious. And therefore, all those modes which want to use or depend on spontaneous mode, one has to be cognizant. Even if one does not measure, I'm not going in detail of how to measure spontaneous effort. We can do it on some other day at the bedside without esophageal balloon manometry. There is a very good literature developing on that too. We need to know a lot of these things in children for sure. But my point of this slide today is this lung stress that we spoke about, where we saw about Epivent, then we saw about Gattinoni's method, and we saw Takesh getting both of them together, is also applied. The same physiology applies to spontaneously breathing patients, because finally it is the lung distension. So this slide is only to show or to bring to our concept of the concept of dynamic transpulmonary pressure, which also is important and helpful at the bedside to titrate. Now, are we going good with time? I think we have some more minutes. We can do a little bit on how do you measure transpulmonary pressure using esophageal pressure. Though there's a very good video which is probably available on the Plug website, which is Plural Pressure Working Group, or I can share with you guys the link, which is made by Dr. Rabinder Khemani, Justin Holtz, and Chris Newth from CHLA for measuring esophageal balloon manometry in children. One should see those videos, and you'll get much more idea and clear steps of how to do it. But if you want, we can go into a little bit of details on this. Let me know.
Please
Yeah, I think
carry.
we can go ahead, Bhushan. Just
Mhm,
before a couple of questions. I mean, you told about direct and indirect measurement of transpulmonary pressure. There is also
mhm,
a lot of like controversy in terms of how do we actually what constitutes a correct transpulmonary pressure. Like one
mhm,
the Tama article you mentioned about direct. There's also a release derived measurement, correct? So where they look at a different technique of measuring transpulmonary pressure. I mean, even the transpulmonary catheter. There was a study which is published. Let me, if I can't recollect properly, but they call it as release derived measurement, where they look at
mhm.
delta airway pressure and delta difference between the peak and delta difference at the end of expiration. Um, so you look at the pleural
Mm,
pressure and the peak pressure at the inspiration, the
mhm,
difference,
mhm.
and the difference between the expiration between the alveolar pressure and pleural pressure, and look at the difference, and that they call as transpulmonary pressure rather
Yeah,
than
that is
looking.
driving transpulmonary pressure,
Yeah,
but you're right. So the inspiratory transpulmonary pressure minus the expiratory transpulmonary pressure is the driving transpulmonary. I didn't go into too much of mathematics because it builds more confusion at
yeah, it's
times.
already
We
already
can,
gets too complicated. Exactly.
yeah,
Uh,
it does.
yeah,
So for instance, let me just go back to this calculation. Here it doesn't populate that value directly, but for instance, you have this inspiratory transpulmonary pressure is 5 and 1. Now in the method that you're talking, which is direct
yeah,
measurement, this 1 minus of minus 2, which is 3, would be the driving transpulmonary pressure of the lung, which is to say that 3 centimeters is used to give the tidal volume. Driving would
correct.
mean delivery of tidal volume, whereas on the ventilator we are using 14.
Mm.
Right? So 3 is being used for the lung. Now, because we know that this 3 is not for the entire lung, this is mostly for the dependent lung, it would be probably 5, maybe minus 2. I don't know this again because the non-dependent expiratory transpulmonary pressure is difficult to measure at the bedside right now. So this value does not populate the driving transpulmonary, but you're right. The driving transpulmonary, and I've used this in my papers as well in prone position and stuff that we spoke on the first session, that the driving transpulmonary pressure gets better uniformized in prone position, at least in peaks. But this is what you're talking about, the inspiratory PL minus the expiratory PL, which also gives you a value of what the lung driving pressure is or what the pressure is being used to get the tidal volume inside the lung. I agree.
Yeah,
But all of this
another
gets
way
very
is just
confusing as
looking
you
at
add
the
mathematics.
pleural pressure swing during inspiration and expiration, where you just look at the pleural pressure during inspiration and during expiration and talk about transpleural
Yeah.
pressure.
So, yeah. So the pleural pressure swings is this is the way elastance ratio will be calculated. If you see here,
Mm.
this ratio gets calculated based on delta pleural pressure, which is pleural pressure swings,
Yeah,
right? So pleural pressure swings, what you're talking is the change from inspiratory to expiration is inspiratory pleural pressure minus expiratory pleural pressure is the swing of pleural pressure. The swing of pleural pressure gives us an idea of the chest wall elastance, and therefore indirectly it gives an idea of the ratio of elastance of lung to elastance of respiratory system. The swing of esophageal balloon comes from Professor Gattinoni's work.
yeah,
Yeah, all of that mathematically will get tied in, but it needs to be done a little bit carefully and understood what we're doing. More important is what is the physiology. And then
yeah,
once you measure the swings, you know that more the swings, for instance, in this example, as we said, this is where the swings in esophageal pressure are larger than the swings in esophageal pressure here, which suggests that if you have a lot of swings in esophageal balloon, then the chest wall elastance is higher and the lung elastance is maybe not that bad and you can use more airway pressure. But if the esophageal pressure swings is not that high, then large part of the poor elastance that we measure on the ventilator is because of the poor lung elastance. Go ahead, Rakshay.
Yeah, please go ahead. And also, I was like, I can't recollect well. There are indirect ways of without a. So, like you just said, there are a lot of issues with how you measure transpulmonary pressure, because there are people who have used air-filled balloons versus water-filled balloons. Compliance of the
Yeah,
balloon itself in terms of giving it a correct value, because absolute
yeah.
values might not be more important, but the swings are more important, and they do
Yeah,
migrate up and down, and then they might not be always exactly in the lower
yeah,
one
yeah.
third of esophagus.
Yes,
Yeah,
yes, yes,
so I
yes.
think that's why I think this topic, what is saying how to measure fluid pressure, is probably quite important, because there
Yeah,
are concerns with regards
yeah.
to many aspects of the measurement too.
Yes, agreed. Like every bedside technology, one needs to be careful and perfect in what we're measuring. For instance, a CVP, if the zeroing and leveling and stuff is not well, then that value will probably not tell us what we need to know. So very similarly, esophageal pressure also needs attention of how to measure it. But once done it well, it gives us very good and dependable values. And that's the beauty of it. But it is challenging, and therefore the interest to do it automatically is much less because it takes a lot more effort in understanding the physiology of the esophageal balloon itself and then measuring it correct, etc., etc. So that is what I wanted to say, is that the effect of this talk shouldn't be that everybody should, oh, we just have to measure it right up front. No, that's not how it will happen. It'll take good amount of time for one to get used to what this visual balloon is, doing it bench testing, measuring it within the water, etc., etc., and then doing it in kids who are not very complex, etc., understanding whether what we're measuring is right or wrong. So it is a challenging thing to do at the bedside, to be honest. Now, why we measure this visual balloon as a surrogate of pleural pressure, as Takesh showed, as what I showed in the pics for prone and supine, and many other places, and it has been shown many times before. Professor Catino and several others have shown it. We are not the first, certainly. The esophageal pressure, esophageal catheter, which is placed in the esophagus, is very close to the juxtaesophageal pleura. Now,
high pressure oxygen or low flow oxygen also you can use through flow.
I think somebody needs to be muted. Okay. Now, this area, which is measuring the pleural pressure close to because the esophagus in the lower one third of the in the esophagus, which is right behind the heart, is so close to the pleura, the pressure changes in the esophagus are very close or similar to the pleural changes. The the problem is that what we measure in the esophagus, we believe is the same as pleura here. But is it true that it is the same everywhere else? Certainly not. And that's what Takei showed, that this one is probably close to what you measure here, but not here. So, however, we can't at the bedside measure this until we have some technology that develops to know non-invasively the pressure between the lung and the chest wall. Someday that will develop. But for now, we have this invasive tool, which can give us at least a measurement of pleural pressure around the esophagus in this area and can help us titrate ventilation by good mathematical sense and by good physiological sense, more importantly. So that's the reason why we measure esophageal pressure. Now, I didn't prepare this as a very detailed thing because this independently is an hour talk of how to measure esophageal balloon. But for those who are familiar, have seen esophageal balloon, there is a technique that one needs to make sure about its placement. There are two things one needs to make sure. A is the balloon volume, which we'll see in the next slide, which is the non-stress volume. And B is its placement inside the chest, inside the esophagus, in the right place, so that it gives us the measurement of the juxtaesophageal pleura. For instance, in this example, just to broadly explain what I'm talking, uh, there is an adult nutrient catheter which has two balloons, actually, gastric balloon and esophageal balloon. And that is the one which is used in this example. So here we see the airway pressure which is going up and down. Esophageal pressure is not connected. The gastric pressure is connected. The tube is inside, actually. And you see with airway pressure going up and down, you see a positive deflection of the gastric balloon. Now you connect the esophageal balloon and you see, oh, it's going up. Like the gastric balloon, the esophageal balloon is also going up. What does this mean? That this is actually probably deep, because when you're giving positive pressure and things are going up, both of them, which means both of them are probably inside the stomach. So maybe, and so you say, okay, let us just try to pull this out. In this example, 5 centimeters of water pressure catheter withdrawal was done, and the patient was allowed to breathe spontaneously. Pressure support level was decreased. This was to amplify the negative swings of the patient. So patient will breathe harder. This is on pressure support. Patient breathes harder, you will see a negative swing in esophageal pressure. So the esophageal pressure should drop with negative pressure, and the gastric pressure will go positive. When we breathe, the intrapleural pressure inside the chest becomes negative, but the pressure in the abdomen becomes positive. And that's what you're looking for. The signal is that esophageal pressure is negative, but the gastric pressure is positive. When that is happening, probably you're getting to a very good place of your positioning this esophageal balloon. So in this example, they kept withdrawing further 3 centimeters of withdrawal, and you see more swings and then more swings and more 2 centimeters of withdrawal. You saw that swings became much more better and uniformed, and you see a good cardiac oscillation. So a good cardiac oscillation is a good sign, because that means you're right behind the heart. And then you're seeing not a hugely pronounced negative swing, but a good amount of negative swing and a good amount of positive swing in the gastric balloon. This is to illustrate the point that A, it should go deep, and then you can come back up steadily. You'll see good oscillations to start with, and a negative swing in the esophageal balloon with a spontaneously breathing patient. This is just one point here. The second is this slide should have come above, is the occlusion test. Now, what is an occlusion test? Once you've come to that position, this was explained by Bedur and colleagues back, I think, in 1980s, is to know the swings in the esophageal balloon and the airway pressure independent of the airway pressure itself. What am I talking about? So what you do is an end expiratory occlusion in a spontaneously breathing patient, for example, here, and you see the patient's effort, which is esophageal pressure, or patient effort is seen here. The esophageal pressure is blue and the airway pressure is red. When the patient takes an effort, you see an esophageal pressure and airway pressure both swing negative. When the proportion of the swing is similar in both, that means there is no contribution from the ventilator, then the placement is perfect. That means the airway and the esophageal pressures are talking the same story. So, and how do you know that? You take a ratio of airway pressure here minus airway pressure here. So both red, which is probably say inspiration and expiration, and divided by the difference for the same points on the esophageal pressure. The ratio should be 1. It could be between 0.8 to 1.2. So about 80 to 120% of the airway pressure, esophageal pressure should reflect that value, which would mean that now it is well placed. This is called occlusion test or Bedur's maneuver. If the patient is not spontaneously breathing, is very sick patient, and you're even better, you do a occlusion test with this end expiratory occlusion. There is no flow, ventilator is not contributing, and you do external chest compressions, 3 of them, which means a force independent of the ventilator has been applied, as was the diaphragmatic force here. And you see that the change in both the airway pressure and the esophageal pressure is similar, of the similar magnitude. Then the esophageal pressure is well placed. This is very key to making sure that this is in a good position. This is called as Bedur's maneuver or occlusion test. Please look it up. And then is knowing the non-stress volume. As we know that esophageal balloon is a balloon in itself. So you can appreciate that if that balloon is underfilled, then the pressure around the balloon will be under-recognized. And if this pressure is overfilled, even little changes around will show huge changes in the esophageal balloon. And if we measure it wrong, or if we get a wrong value which is not dependable, we will make it will make not sense. And if we titrate ventilation to those wrong values, we'll do wrong things. So it is imperative that we have the appropriate non-stress volume. Every catheter from the manufacturer comes with a label of what the appropriate non-stress volume on it is. But those are factory settings and they've been done on bench testing, etc., etc. Human physique, length, weight, size, especially in pediatrics, is all different. And so as this paper by Dr. Brochard and colleagues in adults, and as Dr. Chris Newth and Ravinder Khemani have suggested in children and published, and my experience, one should never use those balloon volumes. One has to titrate a balloon volume at the bedside all the time. It is well shown in that video that I just said. But what is it that we're trying to look for? This is more to understand the principle. The way to do it, one will have to do it many, many times, go through that video, make some errors, learn, and then one will get better. What I think, and of course, there's a matter of controversy, and it is more from my bias probably because I know to use it, is the difficulty of using it should not prohibit us from using it. That is not what should happen. If it is making physiological sense, and if one wants to do it, one can do it with appropriately done values and measurements. Yes, it should be set. One should speak with an expert and take time, have 1 or 2 designated people in the unit, and it should not just be on a fly. Once we did it, it was all right. That's not how it is. It has to be taken very, very seriously. But because of its difficulty, majority of people don't intend to do it until the technology develops of something which is automatically going to measure very nice values. When that comes, we'll be relieved of this pain. But until then, this is what is a good way to do it. And a lot of adults do it, so I don't know why should pediatric folks not do it. Now, just to illustrate this example, the filling volume, this is the filling volume of the balloon. This is in adults. And this is the esophageal pressure at the end of expiration, at the end of inspiration. So this is inspiration, this is expiration. As you fill the balloon volume, as you go increase the ml to 8 or 9, you'll see that initial increase in volume shoots the pressure up, then the pressure kind of a little bit plateaus, not really, but becomes slower and the slope becomes much low. And then again, there is a steep increase. The esophageal or the inspiratory also follows the same curve. The value of the balloon volume below this, where the slope is steep, and above where the slope is steep again, are indicating underfilling and overfilling. This is not where we want to be. Which is to say, the balloon volume during which the esophageal pressure was largely static or more flatter is the non-stress volume, is the volume which is not stressing the balloon too much. It will never be a flat line because esophageal elastance independently will contribute to what you're measuring within the esophagus, independent of the lung and the chest wall elastance weight of the lung. I did more of a clinically approach and mechanical ventilation related talk, but there can be much more deeper physiological talk is what does pleural pressure actually mean? It means A, chest wall, B, it means airway pressure, and C, it means lung weight. So there are 3 components to it, and 3 one will have to know at the bedside which one is working. That comes from intuition, from clinical understanding. But again, not having the information is not a good idea. I think this is my bias. I think we should have the information and then use it sensibly, not driven by epidemiological studies. That will again take us to a wrong path. So in this example, they chose volume best here because this is also steep. So we want to choose the volume somewhere here. And how did they do that? They also looked at inspiratory portion. Wherever they got the maximum swing, which is maximum difference between inspiration and expiration, they considered this as the best volume because this reduction in swing is because above and below is because of esophageal elastance. Is the esophageal elastance probably comes to this best value where the balloon is allowed to inflate in the non-stress portion comfortably. This would mean that your balloon is well placed, is well inflated. It has a proper non-stress volume, and now whatever it will measure is going to be dependable. The balloon starts deflating over time. So once you measure a non-stress volume, you write it down on the chart somewhere safe, and every time you want to do a measurement, which probably should not be more than twice a day, this is not something that you need to keep doing every hour, then you need to refill the balloon with the volume best and then remeasure the mechanics and titrate ventilation accordingly. Why are both steps necessary of, that Beidur's maneuver of occlusion test and non-stress volume? This is because only at volume best, which is at this volume in that paper, is the relationship between esophageal and PS more linear. Apart from that, this ratio of esophageal to airway pressure relationship is all haywire if your volume is not proper. And that relationship of the delta esophageal to delta airway pressure, which we said between 0.8 to 1.2 or 80 to 120%, or rather close to 1, is key to knowing that your esophageal pressure is measuring the right thing. And that probably is best between 0.1 when you're at volume best, which is understood. So this is the reason why we should have both steps done linearly. As much as it sounds very hard and difficult, like with any other technology, with any other instrument, etc., once you do it 5, 10, 20 times, it becomes easier. Then you know, okay, what you're doing. All right. Now, esophageal balloon can help us understand asynchrony and spontaneous effort and stuff, but I think that will leave it for another day. For today, I think this is enough learning load.
Yeah, thank you so much, Bhushan. Amazing as always. Quite useful. I was very keen on starting transpulmonary pressure monitoring in our unit, and I did a bit of literature reading and trying to understand. What it appeared to me is lot of experts kind of were divided in terms of its
Yes.
utility, and some felt its utility probably is more in someone who is spontaneously breathing, because there's no other way of knowing a driving pressure in spontaneously breathing patient because of the swings in pleural pressure which can happen, and the asynchrony, the lot of reverse triggering, missed triggers. So those it's probably more beneficial than actually measuring a transpulmonary pressure. So I just wanted your thoughts on that. And second, I shared an article to you. I'm not sure. I'm not sure if you have seen that article. It was quite interesting article from physiological point of view about not transpulmonary catheter but measuring transpulmonary pressure. So they have this called what you call as step PEEP method, where they sequentially increase the PEEP, and they had a spirometry in their ventilator where they could measure changes in the volume in the lung at the end of expiration with the changes in the PEEP. So that negated the chest wall compliance part of it, and using a driving pressure equation, they could derive what the transfer pressure was. So that sounded very attractive. But only thing is you need a spirometry which can actually measure end expiratory volume. So they use delta changes in the end expiratory volume to delta changes in the PEEP, and that ratio they used to measure the pressure, which kind of gave them driving pressure, which actually told about what is the actual driving pressure which lung is seeing. So these two things, just want to get a sense from your experience. Where do you think you found it to be very useful? Did you find it useful in all conditions, or in those conditions where chest wall compliance is a issue?
Yeah, this is a very, very important question. First, thanks for sharing that article, because I was not aware of that method, to be honest. And where is it going to be most useful? So I think it is back to clinical understanding of the patient, of where do I think physiologically is this patient's ventilation should be titrated. For instance, if the patient is obese, has abdominal issues, do I think clinically that the chest wall compliance is too bad? Then probably it is worth, and is a ventilation, or he or she is a ventilation challenge. Then probably this is a place where, upfront considering esophageal balloonometry will be helpful to understand some of the ways we can negate the effect of chest wall compliance or elastance. Will I do it in all patients? For any division to start learning a technology, maybe you will have to do it in patients more than what is required. But eventually one will learn that, okay, vast majority of patients probably may not need all of these technologies. It is like, does every patient with septic shock who comes with little bit hypotension need a CVP? No, does not need a CVP. Probably vast majority also do not need a urinary catheter, and we can simply do with clinical physiological measurements, blood pressure, pulse, etc., and we can get through them. But there is a subset which will end in ICU and will have more significant problems and will need everything in them, all invasive monitorings. Similarly, so those are ventilation challenges where I think clinically looking at the patient, oh, the chest wall probably has a huge component here and I better know the pressure than do something unsafe. Then this is a patient that I would like to measure. In most patients with ARDS, at least in the adults, it is becoming understood that how the transpulmonary pressure and stress relate to outcomes. There is a very good paper from Lu Chen I'll share with you on a registry basis of how transpulmonary pressures and all of those things or sophisticated mechanics relate to outcomes. So probably there would be, that is how I would select one. Second, as you said, if the patient is asynchronous or the patient's effort is quite huge, or I'm not able to understand the effort exactly because the patient is very obese and he's in a pressure control mode. I'm trying to reduce the tidal volume, but the tidal volume that the patient takes is very huge, which means the patient is breathing harder. But I'm unable to see it just because of certain clinical factors. Then how do I know what actually the patient is doing? In which case, doing esophageal balloon manometry will help understand what those negative swings are like. Of course, all of this every technology will have its limitation and challenges. Parallelly, there is a very good literature that is developing of how can we use a ventilator itself to know the amount of spontaneous effort, for instance, P.1, or a plateau pressure during spontaneous breathing in pressure support ventilation, or end expiratory occlusion pressure, which is POCC. There's lots of literature and very, very cool things that is happening at the bedside for spontaneous breathing.
That's true.
So, but all of those have been standardized somewhere to esophageal balloon or at times Nava catheter. So my personal thing is to use the esophageal balloon because it gives more than one information. For instance, POCC can give you a spontaneous effort, but it can't tell you chest wall compliance. Same with P.1, etc. But if you do one instrument like an esophageal balloon, in that patient, you can get a lot more information at any point in time, be it spontaneous breathing, be it asynchronies, be it chest wall compliance, etc. Now, why are people divided? People are divided because everything will not give us a uniform result. And for those who are driven by epidemiological sense, physiologically targeted methods become less relevant or important because, oh, a large randomized control did not show any benefit. What is the whole point of doing this? Which is, in a way, a good argument. It's out there, and we can argue that if something in large trials does not show a benefit, does it mean that it is all useless? A large trial of Peep of 8 versus 14, I don't even know how could one develop such a trial. In the New England Journal of Medicine in 2004 showed no difference between the mortality of the two groups. And then the Italian group, Crassoin group, and colleagues showed that in one group, you gave inadequate PEEP, in another group, you gave high PEEP to at least some portion of patients who could have been saved. So if it was physiologically titrated, some of the patients who received very high PEEP should have been in the low PEEP group and they would have survived better. And opposite is true for the other group. So even if the mortality was same in two groups, it was actually high in both groups because it was not properly done, which is very, very concerning, right? It is possible. So if we drive ourselves with only epidemiological methods, which for a physiologically titrated therapy is sometimes challenging, and I would request everyone to read Brian Kavanagh and John Laffey's commentary in, I think it was in Lancet, of why all research in critical care is wrong. There was a very bold title, but that is because we don't do good patient selection, or it's not physiologically based. It's just bunch patients together in one group, bunch patients together in another group, and then we say, oh, the result did not show us what we wanted, so let's keep this out. That is not going to happen.
Brian gave a very good talk in Bangalore on why randomized control trials are a big farce and in a critical care context that cannot answer majority of questions. And I always felt so because even when you say septic shock, there's a wide variety of septic shock. We haven't been very smart enough to identify a homogeneous group of patients. The septic shock is a heterogeneous combination of variety of physiologies, and we try to put one therapy and declare it to be useless. And even with the ARDS, I think over time there's so much of heterogeneity in the illnesses. And if you, it's interesting actually when you see a lot of studies with ARDS, the mean ventilation day is 3 days. it never would occur to us that ARDS would just need 3 days of ventilation. But then this is how inability to define a condition properly leads to a lot of conditions which are not ARDS to be included in trial, and then you declare every therapy is useless. So,
Yeah,
our
exactly,
inability
exactly.
to define an illness has limited
Yep.
many therapies and their utility.
Yeah. Just last 15, 20 days ago, Dr. Gattinoni and Marini wrote a very, very nice commentary saying that should we abandon ARDS, as in ARDS is a man-made syndrome, as what Dr. Martin Tobin would say. This is because, you know, this is this is the irony of modern medicine that, and when I was a fellow, I used to think that these old timers don't know what medicine is because we know what ARDS and what septic shock is, but actually we made it wrong.
Yeah,
The whole time would say, okay, this is malaria, this is dengue, this is pneumonia, this is how specific personalized medicine was, and that is
correct,
what we
correct.
probably need to go back to. But we said, no, all of this is just a common physiology. You don't need to call them different, and that's how we have
Exactly.
taught. And
Now we realize gram negative behaves differently, gram positive behave differently, various
there you
viruses
go.
behave differently. They don't have same risk.
Exactly,
Yeah,
exactly. And therefore, this whole debate of is COVID-19 ARD is different from ARDS, but then most sensible answer to that is that actually there is nothing like ARDS. It is a COVID-19 pneumonia. There was a staphylococcal pneumonia. There was a
correct. Yeah,
pancreatitis and secondary lung leak, etc. So each of those were independent syndromes. This is how medicine was originally taught, but I think we made it more confusing. Now that's a very independent and philosophical discussion. But when we derive information or when we derive guidelines from only randomized controlled trial, I think, and as I come from pedigree of Brian Kavanagh, we are likely to make more mistakes than make a sensible argument towards using good physiologically derived therapies. And as I said, it's my bias because I like to do more physiological things, and at some point probably will do more biological things. I think using esophageal pulmonary is a very cool thing at the bedside. Of course, one has to be very sensible of what one is doing. One cannot just use some values in the literature. Okay, this is not good. Let's just do it like this and like that. That kind of stuff.
I agree with you, Bhushan, and I think that's where the importance of basic science related research come, because you're trying to understand the physiology better. You're
Yeah.
understanding what actually works and what is it, the causal relationship in terms of defining therapies with its effect or injury with the basic
Mm-hmm.
science research, and that you need to have a clinical acumen at the bedside to apply it, because understanding the physiological principles guiding
Mm-hmm.
therapy probably is more important in critical care than doing an RCT on one therapy and figuring out whether it's useful or not, because we are dealing with significantly heterogeneous population, and then
Mm-hmm.
no matter how you make your inclusion criteria, I don't think we have reached that stage of refinement in critical care where we can have a very homogeneous group. But it's not like a diabetes or a patient with specific cancers where they're very homogeneous disease and you can actually do a study and
Exactly.
show a difference or not.
Yeah.
Critical care does not really blend itself that well. And I think Brian Kavanagh and many other researchers, I think their whole focus has been in terms of understand the physiology better, because then you know when to use that physiology for applying treatment in a more effective and a physiological way, rather than trying to see whether this works or that doesn't work. It's likely that most of the therapies do work. It's just we don't know which patient population they work, and then we club everybody together and ultimately declare nothing works. So if that was the case,
Exactly.
probably HFO and many other therapies would have been abandoned by now. But despite
Yeah.
having no positive trial, critical care goes on, because if we were to see it for pediatric critical care, where is evidence base for anything? There's nothing. So
Yeah.
everything is a negative trial. Hardly anything which is positive.
Exactly. Yeah, because it is lumping together. That is
Yeah,
exactly the reason.
exactly. Yeah. So thank you so much,
Okay.
Bhushan. It's early morning for you.
No,
Really appreciate
no,
you
that's
taking
not a
the
problem.
time. We've been
But
going through a very
do any
complex
of the
topic.
fellows or trainees have any question?
Yeah, absolutely. So sorry. Any questions
No,
before we head
no,
up?
that's fine. We don't want everybody to listen to Raksha and my bullshit, because we talk a lot of philosophy also at times, but it is more important that trainees get their questions answered. Yeah, as usual, I feel if trainees don't ask, then my talk is not good.
Anyway, it's recorded, so they get an opportunity to go through again and understand it better. So that is a good talk. I
Yeah.
think I'm sure it's quite useful to them. So thanks a lot, Bhushan.
Thank you.
Have a wonderful day.
Thank you.
Bye.
You too. Take care.